دكتور احمد السروي جاهز ولا لسه؟ لسه. دكتور احمد الشريف will show us a challenging case.
فين هو؟ بسم الله الرحمن الرحيم. First of all, I would like to thank you, the chairpersons, the board, and my friend Dr. Farouk Hassan for inviting me and for having me today. Neurointerventional challenges is a very important topic, and we learn most from complications and from unexpected events. Why the unexpected matters? Because neurointervention often follows structured algorithms, usual pathways, until the anatomy, the device, the physiology surprises you. The most valuable lessons come from complications and unexpected events. Ideas are sparked and discussions are generated. The purpose is to highlight unexpected challenges and extract practical lessons. The unexpected event may come from hidden anatomy, device behavior, which may be unusual, hemodynamic instability or abnormal findings like Dr. Mohammed Khalid case, patient factors, team and system limitations that may surprise the surgeon, unpredictable biological responses. I will present a case of MMA embolization, which is emerging as a powerful treatment for chronic subdural hematoma. It's safe and effective maneuver. However, anatomical variations may present, like unpredictable MMA branches that can change the embolization pathway, dangerous anastomosis, which may show connections with the ophthalmic petrous or facial arcades, which may need for super selective techniques. In this case, which is a 3-year-old male presenting with right-sided weakness, upper motor neuron facial palsy, showing this left-sided chronic subdural hematoma after a minor trauma. This is the angiography. What do you see here? Here we see the shadow of the chronic subdural hematoma here, the frontal branch of the MMA, the parietal branch of the MMA, the artery of Hertel's canal, appears here. And the petrous branch of the MMA in one patient. The petrous branch sharing in facial arcade to supply the facial nerve with stylomastoid branch from the posterior auricular artery or internal auditory artery from the ICA. Okay? So here, it's mandatory to go more distal in embolization to make super selective embolization of the frontal and parietal branches to avoid facial injury or blindness. So, although this is safe and effective technique, however, neglecting meticulous examination of the anastomosis may result in disastrous events. Okay, this is a meningolacrimal artery which provides connection. Even simple MMA embolization can result in blindness via ophthalmic anastomosis or facial nerve palsy via facial arcade if anatomical variations are not carefully identified. So in sometimes we may go in the frontal branch and embolize the histoacryl, for example, and leave it to retrograde filling and filling of the parietal branch, which is very risky maneuver, except if you are extremely sure that there is no connection between the extracranial and intracranial circulations. Another case, which is male patient, 40-year-old, presented 4 days, I have 4 minutes, 4 days after pituitary surgery, where an inadvertent internal carotid injury occurred, resulting in pseudoaneurysm. The neurosurgeon was able to control the bleeding with packing. On presentation to our service, the patient was fully conscious with no neurological deficit, and the angiography showed this pseudoaneurysm. The aneurysm is fortunately contained with bone. So we have either the deconstructive approach to sacrifice the internal carotid artery, or the reconstructive approach with flow diverters with the flow aneurysm. Fortunately, also, due to the bone support to the aneurysm, we decided to go with coiling after counseling with the patient and relatives about the 3 solutions, either reconstruction endovascularly, reconstruction sacrificing the artery, or sacrificing the artery with bypass. We decided to go with coiling, then deploying a flow diverter with excellent result. In such case, the patient is secured by nasal packs. So we cannot remove the nasal packs until we are sure that the aneurysm is secured. We cannot start antiplatelets with this patient because removing the nasal packs will result in rebleeding from the injured carotid artery. We loaded the patient with double antiplatelets through NGT tube on table and completed the procedure successfully. أنا هجري بقى شوية عشان عايز أخد رأيكم في حاجة. يعني I will omit case with sinus, transverse sinus. Let's discuss this case, which is female child presented to us at age of 2 years with large mass at the lower back. Her cross-sectional study and the CT angiography show vascular lesion. We decided to follow her without intervention. With follow-up, the lesion came to us after 1 year with this image and reduced size swelling with no intervention, just medical treatment. So sometimes doing nothing is the best thing. This is a 3-year-old female patient presented to me with large head, skin discoloration. She had normal milestones. Comparison of the MRI at age of at birth to MRI at 3-year-old shows enlargement of the W. Angiography shows that she has total occlusion of both transverse sinuses. And the venous flow goes totally through the emissary veins from the bone of the frontal bone and draining to the extracranial circulation through the facial veins. I would like to discuss with you the solution of such a case. She tried many times to treat skin discoloration with laser and cosmetic techniques with suboptimal results due to the facial congestion. So what is the solution? Here we are facing a case of venous outflow obstruction, total obstruction of the normal pathway, the jugular veins. They do not appear in the angiography. And the venous outflow goes totally from the facial veins. Will you give anticoagulation to restore the normal venous outflow, or go with trial for recanalization of the jugular system? Thank you again for having me today, and welcome to your questions.
Any questions from the floor?
Thank you, Professor Ahmed, for this presentation, Professor Muhammad, for this presentation. Actually, I just think about the case with pseudoaneurysm. Did you place a stent, or
Yes.
it was a flow diverter stent, or it was a normal stent-assisted coiling? It was a stent-assisted coiling, or it was a flow diverter? Because
Stent-assisted coiling, but we used flow diverter.
okay, so wasn't this risky for the ophthalmic artery to use the flow diverter across the origin of the ophthalmic artery?
Yes, thank you. This is a very good question. But actually, we were more afraid of risk of rebleeding, because ophthalmic artery and perforators generally are not affected by the flow diverters. Normally not affected.
But I think if you had a normal stent, the stent-assisted coiling, you would go better for this, right?
Yes, very good idea. But so I say we were afraid of rebleeding more. So we, because regrowth of the pseudoaneurysm is common.
Okay.
So coiling alone is not sufficient of pseudoaneurysm. And I have cases of pseudoaneurysms after trauma, clinoidal segment aneurysm who presented after coiling with rebleeding. So we during counseling, we offered only stent-assisted coiling, not coiling, either stent-assisted coiling or sacrificing the parent artery or bypass. The question is which stent to use. Because we were afraid of rebleeding, we chose to put flow diverter, because flow diverter alone may be used. But here, this is a surgical injury, recent injury. The patient is secured only by the nasal packs. So we consider the coil mass as a pack, external pack, and the flow diverter is a constructive technique.
Okay, thank you.
Thank you.